Hello, and welcome to the February 2022 edition of Urgent Care Town Hall, presented by California Urgent Care Association and sponsored by Cepheid. My name is Claudio Varga, and I'll be your host for today's program. The Urgent Care Town Hall, presented by California Urgent Care Association and sponsored by Cepheid, is a monthly virtual meeting open to anyone and everyone, free of charge, where we share and discuss all things related to urgent care, both in California and nationally. The California Urgent Care Association is the state chapter of the National Urgent Care Association. If you're a member of UCA and located in California, then you're already a member of CALUCA. And we urge and invite you to become more involved with us. There's a lot going on, and we welcome your participation. For more information about CALUCA, please visit our website at www.caluca.org. We welcome your feedback and suggestions for future episodes of Urgent Care Town Hall and invite you to be a presenter yourself. Just email us at info@caluca.org. A quick reminder that the annual Urgent Care Association Conference is fast approaching and will take place in Las Vegas at the amazing Caesars Palace Hotel from April 30th to May 4th. CALUCA will host a lunchtime meet and greet, and we'd love to see you all there for real, in person and in the flesh. The final details of this event will be forthcoming very soon. We've got a terrific program today with a very distinguished guest speaking on a fascinating topic. But first, on behalf of the board of directors and our membership, we'd like to thank and welcome Cepheid for their sponsorship of not just today's town hall, but of the entire Urgent Care Town Hall schedule for the rest of 2022. Over a decade ago, Cepheid set the standard for innovation in automated molecular diagnostics, and they've never looked back. Today, Cepheid can boast of having the largest installed base of any molecular platform and is constantly innovating and evolving its capabilities to keep pace with today's shifting healthcare landscape. The Gene Expert System has been heralded as game-changing by healthcare leaders across the globe, enabling institutions of any size, from small medical clinics to urgent care clinics to high-volume reference laboratories and hospitals, to access the speed and accuracy of molecular diagnostics. Cepheid's growing expert test menu spans multiple clinical applications, including healthcare-associated infections, sexual health, critical infectious disease, virology, and oncology. Of particular value during the COVID-19 pandemic has been their PCR Plus system, which delivers speed, accuracy, and flexibility. Please visit cepheid.com today to learn more. Our special guest today has definitely earned the right to share his thoughts and insights on urgent care. Dr. John Koehler founded Physicians Immediate Care in 1987, a pioneering hybrid urgent care OccMed clinic model, which has since grown to over 50 clinics based in Chicago. He frequently serves as medical advisor to multiple Fortune 500 companies. Formerly trained in both emergency medicine and occupational medicine, he has created a web-based, guideline-driven tool that supports both urgent care and OccMed injury treatment and management called OccDocOne. Dr. Koehler, welcome to the show. Please tell us a little about your journey through the urgent care space and what brings you here today.
So I started in 1987 with Physicians Immediate Care, and out of necessity, I had to do injuries. I had to treat injury. I had to do workers' comp, or I would have gone broke and been gone in 1988, early 1989. And so it was very important that I was able to do injuries. And so that was able to provide us with a critical level of volume, critical level of patient volume, so that the revenue was there. It's a high fixed cost model. You got a doctor, you have staff, you have bricks and mortar, you have to be able to do the injury. So that's what I did all these years. Well, now it's a new era. Over the last 10 years, there's been a very significant change in the complexion of the staff, which is working in urgent care centers. We now have PAs and nurse practitioners who, unlike us physicians, haven't done a residency. I had 3 years of immersion in medical care where I'm doing the H&P, I'm following them through, I'm doing all the treatment, and I'm under direct supervision at all times. Well, these APPs don't have that. It's not their fault. This is a no-fault situation. But what has happened in the last 10 years, especially in the last 3 to 5 years, is what I call acuity degradation, where we're simply not treating high acuity cases. We're referring out so many things to where payers are now talking about we'll pay you a triage rate because that's all you do anyway. Or what do you do? Or Humana in Florida, for example, says we're not going to contract with any urgent cares. We're simply going to have nurse triage and have them referred to a multi-specialty group. So this specter of the payer starting to say, you're not fulfilling what used to be your value proposition for the healthcare ecosystem. You are now kind of different. How are you different than a pharmacy-based take care clinic or something like that? So it's it's a crisis of business model. Are we really fulfilling our obligation? Certainly being old school. Roger already mentioned that earlier on the phone here, that we're old school. Us guys are old school. We did ER, we did family practice, we did all the procedures, and we did them in urgent care centers. And now that it's sneaking up on us, by the way, I want to really make that clear that you don't know what's happening. You might not know what's really happening, but I've had to go in and review lots of charts. In fact, I review every first comp referral. That means a first workers' comp injury treatment comes into our clinic. If that case is referred out, I review the chart later. We have lead physicians who take calls and work with them on concurrence on the referral, that kind of thing. They use OccDocOne as their guideline, et cetera, et cetera. But we're still referring out. And the biggest areas of referrals, inappropriate referrals, are fingertip injuries, fractures, and eye injuries. So what used to be basic, like remove a foreign body from the cornea, is now, oh, I don't think I can get it out. Let's refer that. You see what I'm saying? Rust ring debridement. No, because I'm afraid of that instrument. I don't know how to do that. I wasn't trained to debride a rust ring. But that's a basic worker comp ER type procedure. They look at fractures and they don't know what to, every fracture is displaced, right? Okay. I went to our hand surgeon group. I said, what's a displaced fracture? How do you define? They go, every fracture is displaced. So they're referring every fracture because every fracture is displaced. Okay. And, fingertip injuries, every tuft fracture by definition is open and comminuted. So I mean, well, you have to refer open and comminuted fractures. Well, in 33 years, I've never seen osteomyelitis in a tuft fracture. I asked our hand surgery group that question. And they said, no, we haven't either. That's 200 years of experience of hand surgeons never have seen osteomyelitis in a tuft fracture, which is by definition open and comminuted, because the nail bed is open because it's stuck to the bone, right? Okay. So they don't have that experience. So they're afraid, not to be derogatory in any way, but they're afraid of their own shadows compared to what us veteran practitioners of injury management are used to. So we have to fulfill our value proposition. Secondly, and very important, it's us that's doing this. We are creating the industry of orthopedic urgent care clinics. We created it. We made it happen. We don't own them either, because we're taking our cases, put them on a silver platter and just sending them down the street to the orthopedic practice. And they're inundated with tendonitis, strains, sprains, minor fractures, that they just say it's PA to PA or AP to AP. It's a lateral transfer. It's not a quote unquote higher level of care. And they're saying, we got to get an urgent care center here because we can't take this volume in our clinic. It's overwhelming the orthopedic clinics. They don't want their clinics filled up with non-surgical cases. That's a devastating metric for them. Okay, so they had to do it. And we made them do it. And now they're really relevant competitors to us in our neighborhoods. So you got to do them to keep them. Okay. Why don't family docs do gallbladders, baby deliveries, appendicitis anymore? Because they stopped doing it. That's what happened. And now they can't get compensated for it. They can't credentialed for it, and they can't get insurance for it. Guess what's going to happen? Carriers are going to say, oh, we won't credential you for injuries. We'll give you $75 to triage an injury fine, and we'll pay you this much for your illness cases, type of thing. We're going to get squeezed, okay? Right now, you have wage inflation going on. Payers aren't paying you any more money. Where are you going to get it? You can get some more efficiencies maybe with technology, but I suggest very strongly that you do injuries. You keep them in-house. A global fee on a fracture is a lot more than just the first visit E&M code, not to mention the fact that you get the DME, you get the follow-up visits, the rechecks, You get the follow-up x-rays. All of these things are revenue building, visit building, practice protecting endeavors that I would implore all of you to do, irrespective of OccDocOne. Okay, I made a tool, started 3 years ago to make this tool, which is designed to support medical providers who haven't done a residency or who do need experience in counseling and guidance on treating injuries. So let me try to share my screen. Okay, all right, so that's my mug. I'll just scroll this down. So OccDocOne is a tool. It's a web-based tool. And in Quick Check, which is just what it says, you can quick check your cases against what you're doing. You can query by, lumbar, knee, what have you, or you can query by category to look at all the different categories. There's 326 diagnosis-specific guidelines in Quick Check. Not a whole lot missing there, okay? And then I have supplemental content, fundamentals of OccMed. These are the top 12 videos. If any of your providers watch these 12 videos, they will be immediately much more proficient in treating work injuries in the clinic, because obviously work comp is a great source of injury treatment and management. The video library here, this is alphabetical order. There's 400 videos on all kinds of topics where you could put in OSHA here and get all the OSHA videos. You could type in procedures and get all the procedure videos. I do all the injections, all the casting, splinting, all those things. And if you want to look up fractures, I've got videos on all the different types of fractures that can come in to a clinic. So basically everything I know out of 33 years of full-time practice in urgent care, OccMed, I've treated or proctored over 500,000 cases. It's all here on this website, ready and available for any provider to use at their fingertips. Radiology, 250 radiology images where I literally teach in the image so that the provider can see the fracture and then they know how to treat it, because I talk about how to treat it. So it's really important benefit for them to be able to do that, okay? And the screen here, hang on 1 second here. It paused. Let me minimize this. Sorry about that. What I'll do is
John, you can
refresh the screen. Okay, I refreshed it. Okay, so anyway, then there's the CME module where providers can earn CME while using the website. So simply in your daily activities, you can simply use the website, and the tabulation of your time on each of the different guidelines and videos accrues to the module, accrues to the CME module. There's 3 credits per module. There's 14 modules currently. And you're given a notification to take the test. You take the test, you get your credit. You can print the certificate, or you can make a PDF and get 3 credits. And so that is available. It's $10 per credit hour. The website itself is a subscription model, which I'll get to that a little bit later. But anyway, this is back to Quick Check, okay? So that if you're going to quick check a case, you simply type in, for example, lumbar, and up comes the guidelines for it. And you can see there's 6 of them. You'll start usually with lumbar strain. And then, so I have the key history features the provider should know about. I talk about radiculopathy. I talk about cauda-equina syndrome. Under the key exam findings, I give you an exam. So you can watch that exam. These videos only last anywhere from 26 seconds in the case of the eyelid eversion maneuver, all the way to my most extensive video might be 7 minutes. So this is probably 5 minutes. But in the guidelines, I provide the video of the examination. I've had providers tell me, hey, Dr. Koehler, love your website. Now I know what to do when I go in the room. Okay, that's kind of scary. I thought they'd say, well, now I know how to do a shoulder injection. Now I know how to do a running horizontal mattress suture, or now I know how to manage worker comp rechecks or what have you. But anyway, I'm glad they have, at least they're getting help with that. I show you the straight leg because this is anything with the play buttons, a video, straight leg raise test, talk about push-pulls testing. I got the validation steps here, which is really important to rule out malingering with the scoring system, a 5-point scoring system to rule out malingering. Okay, then a step 2, confirm work-related plausibility is how to do it right here in a video about that. And I give the actually what to put on the chart even on what to do with that. So this is something that employers absolutely love. So if you had OccDocOne, you could use this as a sales tool with employers to show them this. They say, wow, do you guys really do that? You say, yeah. They go, oh, we're going to use you because we never get anybody telling us that it's not really work related, you know? And that's a problem everywhere, that anytime someone says they were at work when it happened, they call it workers' comp. It's not necessarily true. Moving on down to the studies, we get the x-ray, how to differentiate acute from chronic compression fractures. We have some providers panicking when they see an asymmetric vertebral body. Then if it is an acute one, they can move to that guideline. I have a picture of a spondylolisthesis here. Then on the working diagnosis, after the history, physical, the studies, you're on the working diagnosis. This area here is the nuances of employer satisfaction. Very important, because employers are looking for any medical provider that will do this stuff. If you actually do this, it's not that hard. If you follow these guidelines, they will be so happy. They'll kiss your feet, okay? And they'll tell everybody they know to use your clinic, all the employers that they know to use your clinic, because you're actually engaged with the things that matter to them. So we avoid excessive restrictions, avoid lost time. We talk about, you know, the terminology is really important. Here's a video about that on lumbar, what to avoid, and then Osha recordability issues for lumbar. I talk about a video with that, and why work restrictions did not necessarily make a case Osha recordable. That's misunderstood. I talk about using non-recordable meds like Tylenol, naproxen 220, ibuprofen 200 on visits 1 and 2. Talk about a back support is not recordable. Here's the Osha reference. I give a differential diagnosis, which helps support a level 4 code in the new CMS guidelines. Then now that we've done the H&P, we have a working diagnosis, visit number 1, triage note. This is very, very important that your providers be careful on what they refer out, because when you refer it out, then you're not doing it. If you're not doing it, then you're losing it. So we treat lumbar strain in-house, refer only if it's cauda equina syndrome, okay? And I've never seen one myself, ever. I've testified on one, but I've never seen one, okay? But nevertheless, it's that important. So I have all the danger points from a medical legal risk management standpoint sitting right here in the guidelines, because they might not know what cauda equina syndrome is. I'm not kidding you, okay? I'm just saying, all right? Then if it's not cauda equina, lumbar strain, working diagnosis, we got the medication in the dosage, it's non-recordable. Pick combination here of NSAIDs. Why we like to dispense prepackaged pharmaceuticals. We give the support, the lumbar support, and here's the code for it. And the reimbursement is good, usually, at least where we are, it's quite good. And if you want any guidance on, the how to use DME, how to monetize DME, then that is something I can connect you with someone who knows a lot about that. Then work status and body mechanics, video on how to set restrictions. This is really important because providers will say, look, I've never done worker comp. I don't know how to do a recheck. I don't know how to do restrictions. I don't know when to recheck them back. I don't even know what to ask them when they come back. It's all in here. Okay, here is when you recheck them, 4 to 7 days with yourself for continuity, why that's important. Then this is a trade secret, make the first phone call. They love it. They absolutely love to talk to the medical provider on the phone because you tell them about the case in layman's terms. I taught a video here why that's important. And then you're done and you move on to the next patient. When the patient comes back for a recheck, visit 2, if they're improving, do this. If they're not improving, do this. If it's visit 3, if they're improving, do this. You're getting ready to, full duty, nearly released on the 3rd visit if they're getting better. If they're not, then you're talking about Osha recordable interventions such as a muscular trigger point injection, a prednisone taper course, perhaps physical therapy. There's a lot of stiffness and spasm. And I'd have a video on the proper use of physical therapy. It's very important to use it properly. It should not be a dumping ground for everybody, okay? And later I talk about, like visit 4, I talk about MRI scans, when to order them, how to interpret them, those kind of things. I have references here that support these guidelines. So that's kind of the overview on lumbar. Let me show you the knee, okay? And it's different, obviously, but you'll be able to see right away. Here's a dozen guidelines on the knee, and you'll be able to see knee strain. It looks the same, but it's different in a sense that mechanism and anatomy in the history, and then physical findings on the anatomy. So by the time you've done the H&P, you have a good idea what anatomy is injured of these choices here. Here is when to order MRI on a knee injury on the first visit, only if it's unstable. Here's the validation steps, which I won't show you again. We get the X-ray. If it's fractured, these are the fracture guidelines you can switch to, whichever are applicable. If it's not fractured, you got a working diagnosis of a knee strain. If you want to get more specific, you can switch to one of these guidelines and follow that for those particular diagnoses. Here again is the nuances of employer satisfaction, the differential diagnosis, visit 1, triage note. Knee strain is treated in-house, okay? And then on down, we talk about the hinge knee support, which is not OSHA recordable, work status, body mechanics, recheck visits, first phone call, OSHA reference on why the hinge knee support is not OSHA recordable, visit 2, do this, visit 3, do this type thing. So you get the idea. And then, you know, I have eye injuries, and I have bloodborne pathogens, head injuries. I'll show you the head because that's important. This comes up a lot of inappropriate referrals to the ER. This happens almost any head injury nowadays is getting referred out. It's really not right. So a video on how to use my assessment tool for head injuries. And then skipping down here, I category red is ER, yellow is outpatient CT, green is they don't need a CT. You need to check them the next day. And all these head injuries get checked the next day. They should all be told, return back here tomorrow morning for a follow-up, because 98%, 99% are negative on their CT, and you don't want them referred to a headache clinic or a neurologist. They'll never get in for weeks and it costs too much. So you got to recheck all these back, and it's like these cases are all hot potatoes. The first thing they can think about is, how do I get rid of this and never see it back? And that really isn't the right idea, because I spoon feed this. This is absolutely spoon fed, everything they need to know. Here's the references, the state of the art references, and category 1, category 2, category 3, very easy to do to follow these guidelines. Bloodborne pathogens, another one that they might not be proficient in, but I've got the same kind of tool here that gives them everything they need to know how to manage a needle stick or a biological exposures event. If you're doing any kind of work comp for healthcare entities, then they will get needle sticks. So that's important as well for you to have in your armamentarium to help service your clients. So that's kind of the overview. The idea is that this will help inexperienced providers get more confident. It holds their hand, takes them all the way through it. The cost of this is $149 a month per clinic. I'm wanting to work with CALUCA, and I'm willing to discount that considerably down to $100 per clinic per month, which is ridiculously cheap for this tool. And if you want to do injuries and you want this tool, this can help you. Otherwise, still, you need to come alongside your providers, whether you use OccDocOne or not. You got to come alongside them, and you have to replace the residency. You really have to, it's got to be like they're in a residency with you to treat these injuries. Otherwise, they will refer it out and you will lose it, and your communities will learn not to come to you anymore for injuries. You'll lose. So here's the thing. You might say, well, just because we refer a fracture doesn't mean we're going to lose injuries. Well, here's the problem with that. Okay. The patients don't know that, but they know they paid twice. Okay. Like if you have a fifth metatarsal fracture or a metatarsal fracture, put a boot on it. That's easier than treating a pharyngitis. It really is. It's unbelievable how easy that is. And you all know that fifth metatarsal fractures, a lot of them, the patients never come in. It was just a bad sprain, foot sprain. They never come in. There's no downside to that. You've never seen a deformed foot come in and say, oh yeah, I fractured my foot. I never came in. It's deformed or it's problematic. No, it's not. It heals by itself. So the boot is kind of like pain amelioration. And in my videos, or on my guidelines, metatarsal, the guidelines on metatarsal fractures. So here they're easy to treat. And I show you pictures of all these that you can treat. So you could compare your metatarsal fracture to this metatarsal fracture. So you can see this is a hairline fracture that's easily treated in the clinic. So this is kind of like helps them out not to be afraid to see all these different fractures. And I talk about, I give a video why we can treat metatarsal fractures in-house. It's that explicit about it. And I give the plan of care, the triage note, the criteria for referring, and the boot, and the code for the boot, and video on how to apply it is in here. So it's really that easy. But at this point, what I want to do is open it up for question and answer with the panel, and just see what's on your mind about this.
Well,
Terrific. Let me see here. We've got our distinguished panelists. Let's see, I got to change my view here. It's complicated. There we go. All right. So yeah, that's fantastic, Doctor. That was really, really fascinating. I'm really, really eager to hear the this roundtable discussion with the clinicians here. I'd like to introduce. Let's see who we got. We've got Omid Akbari. Hey, Omid, how you doing? Distinguished member of the board of directors of California Urgent Care Association. We have Dr. Roger Hicks with us as well, and the two of them have got some questions lined up for you, Doctor.
Sure.
Take it away.
John, I'll lead off if that's okay.
Sure.
That was fantastic. I mean, this looks like an incredible tool that you've developed. Obviously, you've put a lot of time and thought into it, and it's very impressive. So thank you for that. And I have to say, I totally agree with your take on the degradation of the acuity in urgent care. And we're sort of digging our own grave there. So I totally agree with you about that. I guess my first question is, you're based in Illinois. How much do regulations vary state to state or between Illinois and California?
There are differences, which I am not an expert on. That would be something to look into, but the workers' comp has to be treated by somebody. I don't know what the state fee schedule might be or the rules about that and the paperwork required, but it's I mean, someone's got to do the workers' comp. It might as well be our urgent care clinics, and the fees can't be that bad because it's got to be done by somebody.
Right.
I don't know what the fees are.
Right. No, I meant in terms of, yeah, there's a California fee schedule. So, I mean, that works for us. And I just meant as far as reporting requirements and so forth. But my second question is, can you talk a bit about Osha Recordables? Okay. Yeah, I mean, you recommended over-the-counter meds at the first visit because that's good for the employers. Can you talk about that? It's not as good for practitioners in terms of E&M coding with the new, the new levels of E&M coding. If you could talk about that a little bit.
Okay, so I do have in these videos here, I've got the OSHA recordable introduction. So there's a video all about that. So OSHA, Occupational Safety and Health Administration, years ago decided they want to set up some sort of measurement or metric around safety in the workplace. They chose OSHA recordables. So if you hit a certain threshold of OSHA recordables, they could come in unannounced and inspect your factory. And a lot of employees really would rather not have them in there like that. Okay, that's point one. Point two, that for bidding on large contracts with utilities such as nuclear plants, gas company, water, electric, et cetera, that they can go to a website, and all the subcontractors have to post their OSHA mod rate on the website. And if they have an OSHA mod rate that is related to their OSHA recordability cases per hour of worker time, that they could be above the threshold and be not able to bid on contracts. I asked a company client the other day, what's an OSHA recordable worth to you? He said $24 million. I said, what? He goes, yeah, if we can't bid on a contract, it's worth $24 million to us. So ibuprofen 600, which hits the OSHA recordability threshold because it's a prescription level and all prescription level medications are recordable, they could lose you lose the ability to bid on a $24 million contract. So it's very, very important. Generally speaking, that the vast majority of unnecessary OSHA recordables are related to unnecessary prescription medication. Okay, patient comes in, they all get Norco and Flexeril, or they all get Tramadol and Flexeril or something like that. That's a recordable. ERs, urgent cares, family docs, if they write a prescription, it's recordable. And there's a very, very large relevant contingency of employers out there that care an awful lot about avoiding unnecessary. They will come to you like puppies on a pork chop, okay, if you guys can get this right. And obviously I've been doing this now for 33 years and we have a huge contingency. We are taking market share from Concentra in Chicago over this issue because they prescribe PT early and often, and that's recordable. So if a intervention requires a prescription, generally it's recordable. So PT is recordable, prescription meds are recordable. There's a bunch of categorical recordables like suturing, fractures, debriding and rustering on the cornea, all that's recordable. But if you treat it as quote unquote first aid with non-recordable treatment in the first 2 visits, it will really help those clients that really care about that. Large manufacturing firms, construction, utilities, and you can use that as a marketing benefit for your group, okay? Because they care about that, okay, a lot. So OSHA recordable, they have OSHA 300 log in their factory. They have to fill that out on every recordable injury they have. If the case is deemed to be not related to work, then it's not recordable. That's another issue. If you deem a case not compensable under workers' comp based on the validation steps on the guideline, then that case is not recordable regardless of what you do, because you're referring to their family doc anyway, but it's not compensable because it's not recordable because it's not compensable. So that's kind of the rules on recordability. It's a very, very big deal for employers.
And what I heard you say is the lumbar support is not recordable.
Yeah, the criteria. Okay, the criteria is a 2-pronged criteria that is rigid stays that immobilize a joint. Okay, and are intended for immobilizing of a joint or a body structure. Okay, so a back support doesn't immobilize anything. It's a support. I like to use the word support. My guidelines use the word support. Knee support, ankle support, elbow strap, back support, boots, even boots. That's debatable because their foot can actually move inside of it. They can take it off at night. If it's a fracture in the boot, it's not the boot that makes it recordable, it's the fracture that makes it recordable. So a lot of that's a moot point on boots. So it's not that big of an issue. But those wrist supports are a big issue. Knee supports, big issue. They do not fully immobilize the joint because there's movement inside of it. They're only Velcroed on. And the hinge knee, yeah, the hinges are rigid in a sense of the lateral dimension, but they're not rigid in the AP dimension. Flexion and extension is fully normal with the knee. So they're not recordable. So the durable medical equipment that I advise on the guidelines is, for the vast majority, non-recordable. I'm going to show you something in the video library, and this is important too. DME, okay, DME. There's 13 videos here, play button here, 13 videos that show how to put the DME on. I've been in clinics where they say, because I go around the country a lot to visit practices and stuff, and I was in a clinic and a doctor was there and, oh, we don't use DME. And I said, well, how come you don't use DME? And the provider said, because we don't know how to put it on. I mean, they had it in their closet. It was all there, but they didn't know how to put it on, so they didn't use it. Seriously, okay? And they're afraid of it. A dog, by the way, there is a true fear in the heart of any medical provider when they're faced with something that they don't have a mental grid or a mental algorithmic framework with which to deal with it. There's providers, when the worker comes in like this, all they can think is petrification. All they can think is, how do I get rid? I'm afraid to remove the hand and look in the eye. I'm afraid of what to do because I don't know what to do. I don't know how to work eye magnification. Seriously. So wherever you are, whatever you're doing, make sure they have either head mounted magnification or slit lamp, and they're trained on how to use magnification to look at a cornea and how to use an opti spud to take that out. And I have all these videos and all those equipment in here under EQU equipment. So alligator forceps, head mounted magnification, number 11 blade. I have all this stuff in here under equipment. And so you guys have access to all that. And I even have, by the way, I even have a, I'm going to throw this in here. It's kind of a little bit off the subject, but I'm going to show you under OccMed. If you just type in OCCMED, that this is my elevator speech to recruit companies for work comp. Okay.
All right.
I've recruited, I've literally recruited a $40 million OccMed practice off of this elevator speech. If you're using OccDocOne, you can say this with integrity. Okay. Anyway, so that is about DME. So you can use DME, and your staff can be trained on how to put it on.
Great. Thanks.
So John, I want to add something here. And first of all, thank you very much for the presentation. We have been doing OccMed for almost 40 years in our clinic.
Wow.
And I have seen that how important is Osha Recordability for employers.
Yeah.
So they really love if we can keep the patient out of recordability, and
Yes.
they pay for that. So it's like a cash pay by the employers if the employee is not recordable. So that's
Right.
very important.
Yeah. It's like a magnet because they all talk to each other, these safety directors, because their jobs depend on their OSHA mod rate, and they're making 80 to 100,000 a year, and they may or may not have a bachelor's degree. So it's a good job, these safety directors. And first job is safety and prevent a fatality. Second job is OSHA recordability. All of them, safety directors. It's a very big deal.
I also have a question for you, John. As you mentioned, most of the APPs have not been trained for OccMed related conditions. And what has been your experience in terms of onboarding them to use this platform that you have developed and has a lot of information, and kind of encourage them to keep using that to become familiar and feel comfortable applying these guidelines?
Okay. First of all, they should watch these 12 videos. That's like the start. Okay. So, and I do have a recommended onboarding curriculum that I can provide to anybody that wants that. So, and then I tell them they've got to go through the basic fracture guidelines, the basic eye injury guidelines, and the basic fingertip injury guidelines. That's just a warm up. But as you can see, that if you view the categories, they can find electrical injuries, even how to do pre-employment, asbestos, silica, eye injuries, all these things by category, genitourinary. I mean, it's like, well, did you look at OccDocOne? No. Well, why didn't you? Oh, because I didn't think they would have that in there. I've got hydrofluoric acid in here. Okay, so it's all in here. So they need to get kind of immersed in it to start out, but then use it every day. I mean, every visit of any injury, even urgent care injuries, is just as relevant not to refer an urgent care non-displaced distal fibula fracture or a minor, I should call it a minor avulsion fracture, distal fibula, proximal fifth metatarsal, because they're not going to come back, because they're going to learn from ortho urgent care. Why would I go there? And they call their place ortho direct. That's what they say. Come to us directly. Bypass urgent care. It's just an extra bill. So you got to do these fractures. So how to onboard them? I would say you yourself immerse yourself medical leadership from your group should immerse themselves in this too, so they know what to tell their APPs to view and look at. It's kind of intuitive. I mean, again, it's all the fractures. I think there's 65 fracture guidelines in here. There's I think 10 or so eye injury and probably 6 fingertip. These are getting referred left and right, and they really shouldn't. They shouldn't be referring out without concurrence from medical leadership. Because even if they're using OccDocOne, if they're scared, they'll just refer it and you will never know about it. And oh, by the way, there's a reporting function on here. You can actually see by user, by date, exactly what videos and guidelines they looked at that day or over a span of days. Because I knew that would be necessary for you to bring to bear accountability with providers to do their jobs right. And it's up to you to set the standard of care at your place. And UCA is currently working on a basic standard of care levels in urgent care to establish recommendations for what acuity you should be doing to actually help UCA get higher reimbursement for urgent care centers around the country. But you got to reach a level of acuity to qualify to be a comprehensive urgent care center.
Okay. And John, we also received 2 questions regarding the OccDocOne subscription. So the first question says, are there individual accounts, or technically an organization can get one account and assign it to multiple providers in their organization?
Yes, unlimited users, unlimited time on the site, MAs, rad techs, providers, everybody within the organization, be it UBIDocs, okay, that's Dr. Hicks, or be it Carbon Health or what have you, that the organization has the subscription based on how many clinics they have. And then you can register a new provider or a new user, you can register them within 30 seconds. It's that easy. You need their name, their credential, their title, and their email address is all you need to register a new user. And there's thousands of users on the system currently. And it's really easy to do, but it's by organization, meaning urgent care company, urgent care group. The discount applies to CALUCA. If you're a CALUCA member, it's literally 33% less per month. I mean, that's not insignificant. It's down to $100 per month per clinic. So if you have 5 clinics, it's $500 a month. And that's, capturing one fracture case is easily $500. Plus it helps your practice. So like there's downstream benefits to OccDocOne to maintain your position in the community as an entity that treats injuries.
Okay, and you answered the other question too. By the way, we received some comments that a couple of urgent cares, they are very happy with this resource in urgent care. So
great, glad to hear that. Good.
You also mentioned the other staff members like MAs and X-ray techs. Now, I can imagine that watching the DME videos and stuff like that will help them a lot to be able to help the providers. Now, in California, we are suffering from lack of X-ray techs. So many urgent cares nowadays, they cannot hire X-ray techs. Now, what is your recommendation when it comes to injuries, and if we do not have an X-ray tech that day? How can we use this system or any other recommendation to deal with those injuries?
Yeah, the knee-jerk response is to send them out, sort of like get rid of the hot potato because we don't have X-ray today. That's obviously not the right answer. You can still do a clinical examination. You can do everything except the X-ray and apply the DME that will protect the injured body part in case it is fractured. Obviously, if it's a dinner fork wrist and you can see it's a dinner fork, we got a Colles fracture here, it's bad, that you can refer without the X-ray, of course. But when you don't see an obvious deformity, is it really going to be surgical? Unlikely. And they can come back the next day. You splint them and bring them back the next day to get their X-ray is okay. You can send them to one of your other clinics that does have X-ray that day. You can share X-ray techs between clinics so they can drive to your clinic to do the X-ray. And we are currently, and this is state by state dependent, we are currently training folks that are not rad techs to position for x-rays. So we're in the process of being able to do x-rays without a rad tech. It's legal in some states. You should explore that in California. Don't know if it's how you could work that, but clearly it's creating another crisis. And one thing leads to another. We stop doing injuries, which means we have less x-rays going on because less community members are coming in with injuries because they're going to ortho urgent care, lowers your x-ray volume. The rad techs say, you know what, I did 2 x-rays today and 30 drug screens. Why am I here? Or, you know, 1 x-ray and 12 COVID tests and 30 drug tests, you know? So this is a downward spiral, this thing. You've got to do the injuries to get the x-ray volume to satisfy your x-ray techs that they're actually applying the skills they went to training for. So
let me just, there's one other option in California, which is the X-ray or the radiology operator and supervisor permit that physicians can get. So on days when we haven't had an X-ray tech, I go in and take the X-rays myself. And, you know, we have positioning manuals and it's all digital. It's not hard. In fact, the digital screens show you the positions besides the manual. So that is another sort of stopgap measure. But I totally agree with you, John. If, you know, if we don't do the x-rays, that contributes to the shortage of x-ray techs.
Yeah, thanks for that point, Roger. Yep.
And so can you talk about calling the employer at the first visit and how that interplays with HIPAA regulations?
Great question. Okay, first of all, government made a good decision. Wow, that HIPAA does not cover workers' comp because they understood the compelling interest the business has to maintain a safe working environment. The OSHA, the general duty clause, the OSHA Act says you have to keep a safe working environment for all workers. That's kind of the overarching principle of all of OSHA and all of safety, et cetera. And so if the provider, I mean, if the employer is kept in the dark, they can't protect the worker. Okay. So it's a safety issue that the employer needs to know what's actually injured, what the work restrictions are, what the diagnosis is. So obviously you don't, go into the patient's diabetes or HIV status. Okay, for goodness sakes, you talk directly about the knee injury, back injury, whatever the work-related injury was, and what goes on. So it's not covered. Now, ERs don't understand that, trust me. So there's no hope for ERs to be willing to talk to employers about an ER patient. It's not going to happen. They talk to me some of the time because I'm medical director for some employers, and the ERs will talk to me about it sometimes, not all the time. But that first phone call is absolutely legal, absolutely necessary. It's a trade secret. I'm telling you, it is a trade secret. They will absolutely love you. They love that relationship. They love that conversation. If you can simply talk layman's terms to them about the injury, they will love you. There's nothing stickier than that. You've got to do it. You can build a multi-million-dollar occupational medicine practice if you follow these guidelines. In fact, I will guarantee, absolutely guarantee, if you follow OccDocOne, your practice will grow. You'll maintain what you have and grow more by word of mouth, not to mention whether you have a sales staff or not.
And what about calling the employer at follow-up visits?
That would not be necessary, in my opinion, unless there's something else happened, like we ordered an MRI or something happened that, like, their cast got submerged in water at work. How did this happen? Something that you need to talk to them about, this just intuitively, that you would talk to them about it. So there is a coding issue. If there's a phone consultation taking place, it can help your code support a level 4 code. I'll leave that up to you guys to figure that out with your EHR system, but I know that the first phone call helps support a level 4 code. So does the review of a differential diagnosis, which I have in all my guidelines, will help you folks support a level 4 code. Because in fact, and here's another thing, we dumb ourselves down a lot. If you're treating a lumbar strain, a back pain patient, how do you know that's not a dissecting abdominal aortic aneurysm? Get what I'm saying? So So that's, you should be paid for that,
Yeah.
to figure that out. Abdominal exam, you know,
Yeah.
like my legs feel cold, it's searing, tearing, ripping pain, like what's, you know what I mean? You got, that's not Kmart, Walmart stuff. Okay. This is life-threatening stuff. So you deserve to be paid. Absolutely deserve to be paid level 4 for these.
Great. Thank you. Omid, you got one?
I just had one final question for our members. If they want to take advantage of this promotion, how can they contact you, John?
Okay, great. So right here is, can you see my screen still?
Yes.
Here's
Yes.
my phone number and here's my email address. You can just email that to me and just say, hey, I'd like to get on a Zoom call and talk further about it. You can call me and we can just talk over the phone, whatever you'd like to do. Very easy to set up. I can send you a draft subscriber agreement and you can review that. And it's very simple.
Okay, thank you.
Yeah, wonderful. So for our people that might be just listening to this on their phone or something like that, Dr. Koehler's phone number here is area code 815-415-1234. You nailed that one, didn't you? So
I
815.
might add that speaking of cell phones, we do have the app in the App Store, OccDocOne. Providers actually take their cell phone in the room and they look at it to know the questions to ask. So
Nice.
by popular request, do you have an app? Yes. Okay. So
It's fantastic. I mean, you are the up-to-date of occupational medicine.
Exactly. Yeah.
So congratulations, John.
Thanks, Roger.
Super.
I want to make one last point about case rate contracting. If you have to do it, and I'm not running your business, but if you have to do case rate, carve out x-ray for goodness sakes. You got to get paid for your x-rays. If you can carve out suturing, carve out fractures, really, they want you to sign case rate contracts because they know that cuts what they have to pay you dramatically. Okay. So to do injuries and get paid for it, try to avoid case rate contracts. Meanwhile, there should be no case rate contracting in workers' comp, which makes worker comp even more attractive because you don't have that.
Great advice. Great tips. Thank you so much, Dr. Koehler, for being here today. We really, really appreciate you taking the time and out of your busy schedule and sharing this stuff. It's great to see all the comments here in the chat screen. Happy customers, and we've heard, when I was researching, this, getting ready for this, I've heard nothing but great things about your products and just a wealth of experience and just the focus that you have in OccMed, which is such a complicated thing. Really, really is. Seems like you've managed to put the magic in a little bottle and make it easier for everybody. So
Yeah.
congratulations for that. That's
Thank you
terrific.
so much for this opportunity as well. Appreciate it.
Yeah. So thanks again to all our viewers, our CALUCA members, and all you folks from outside of California. Welcome, and tell your friends. We're here the second Thursday of every month. What is the date? I had it on my calendar and now I put it away. What's that's going to be in March, Thursday, March 10th at 12 noon. We're going to be here as well. And also keep an eye on your email inboxes for that information on that particular presentation, and also an update on the meet and greet where you can meet us and fellow CALUCA members in exciting Las Vegas in a couple of months' time. We're all very excited about getting out there in person again. So until next month, take care. Thanks again, and everybody be safe out there. Goodbye.